If you're considering a career in medicine, this show is for you. I'm going to be talking to a variety of healthcare professionals who are going to share the reality of what it takes to have a successful career in medicine. The good, the bad, the inspiring, the funny. My name is Michele Neskey. I'm a physician assistant and your host, about to bring you Beyond the Scope. If you've done research into applying to physician assistant school, you know how crazy it is with all the different requirements and programs out there, and how do you choose which one is best for you? Well, luckily, two of my friends and PAs created an amazing platform that you can do this all in one place called My PA Box. Research schools by state, track your hours, look up all the requirements, literally in one spot at mypabox.com. You can also use their PA school match to enter in all your demographic information, your GPA, whether or not you took the GRE or PA CAT, and filter for schools that would be the best fit for you. You guys, this has been game changing for pre-PAs, and I use it all the time with my clients. You can go ahead and get a 1-year subscription. And because you're listening to this podcast, if you use Posh PA 15, you can get 15% off your 1-year subscription. You will not regret this if you are a pre-PA. It will sort things out so much for you and just make it easier to do the research on the programs that are the best fit for you. So check them out, mypabox.com. Okay, here we are. So you guys, today I am with Joel Silik, who is a PA out in Washington. So he's been on the front lines of COVID out there in Washington, and we're going to talk about that at the end of this podcast. But first, we're going to talk a little bit about kind of how he got to where he is now, because he's a new grad, I guess. Not really, been out a year. So we'll talk a little bit about the learning curve and what that's been like, and why he chose to specialize in ophthalmology. Eyeballs freak me out. So I definitely am interested about that. So Joel, why don't you tell us a little bit about why you decided to become a PA and how the application process was like for you?
Yeah. Well, first off, thank you, Michele, for having me on your Beyond the Scope podcast. Really excited to be here. So I joined the physician assistant career when I was 15 is when I started. I started college
15, like 1-5?
1-5, because
Wow.
I started college at like 16 and I knew I wanted to go to PA school. So I was doing all those prereqs.
How did you know that? Do you have like family members in medicine?
No, so I have no one in healthcare. I
Okay.
was literally sitting in the library at my college and I saw the PA career online and just thought that was cool.
Cool.
No really cool story.
Okay.
So I started the prereqs and was going through all that. That was locally here in Washington State. Then I transferred out to a school in Virginia. And I guess the reason how I chose ophthalmology and PA kind of are coincided. So I'll kind of answer those both at the same time.
Yeah.
I was at a school in Virginia for my undergrad. I had a 1.5 years there after transferring out from my college in Washington State. And I was just walking along and there's no one from Seattle out there. And there was a guy in this like Seahawks jersey. And he became one of my best buddies at college because I just went up to him and introduced him and shook his hand. And we became best friends. And his dad was an ophthalmologist. So his dad was encouraging me to do ophthalmology. So I graduated, went back to Washington State. As everyone knows, to go to PA school, you have to work in healthcare and have hours of experience. I didn't have any of that. So I shadowed a family friend optometrist and just spent like a month shadowing him. And then they offered me a job. So then that's how I got my patient care hours, was getting on-the-job training to be like an ophthalmic technician, which basically is someone that gets the workup for the doctor, vision, pressure, pictures. Then it became a scribe for the physicians. And then they taught me to be a first assist in the OR doing cataract surgery, refractive surgery, and cornea surgery. Yeah.
Wow. Okay.
And then they also helped me with research. So in Washington State, our clinic was one of the first ones to implement what's called dropless cataract surgery. So normal cataract surgery, you have to be on 3 different drops afterwards.
Okay.
The dropless cataract surgery, you like inject the medication into the eye, so patients don't need to be on drops. Because of that, then I was able to do research and present that at ASCRS. It's the American Society for Cataract and Refractive Surgery in LA, and kind of was able to dabble in all fields of medicine, whether that's research, clinic, OR, things like that.
Okay.
All prior to PA school.
That's cool because, a lot of people think of like the traditional patient care experience, like EMT, MA,
Hmm.
all of that. And sometimes we forget about these other opportunities like, what is it called again?
Ophthalmology.
Ophthalm
Yeah, that happens all the time. Well, and I like
tech.
that you say that because um, like what I said, it was on the job training. I didn't pay to go get a credential. I was
Right.
getting paid to learn and getting paid to have a wide range of exposure. Which, if a lot of you are out there, a lot of eye clinics function this way. A lot of techs are on the job training. So if you're looking for patient care hours, that's probably a good option to look at.
That's a
Um,
good idea. That's not, now this is different from like an optometrist, correct? Like this is not the person you go and see at Lens Crafters.
no, no,
Okay.
yeah,
This is like a legit ophthalmology office, with
yeah, medical
ophthalmologists and physicians.
ophthalmology.
This is not like, okay. Because I think people
Mhm.
get confused by that. I had somebody reach out to me about being an optometrist, like tech at,
Mhm.
and I'm like, I don't think that, it's hard for me to know.
Mhm.
But that's a totally separate practice than like a medical
Ophthalmology.
practice. Yeah.
Yeah, it is. I mean, you could still do a lot of what I did in an optometry setting, like a lens crafters, because it is still patient care. But I think you would miss out on a lot of the pathology just because that is
Hmm.
more optical in nature, just glasses,
Right.
which we still do that, but you get to do all the medical side. And I think that's what's going to shine in your PA school application. So
Right.
definitely look at more a tertiary type of a eye clinic that
Okay,
provides
cool.
spectrum services. Yeah.
Yeah. And then so when you were kind of moving all around, you were still in college, right? So this was all
Hmm.
prior to PA. So when did you apply and why don't you throw out some of your stats to people?
Yeah. Oh gosh, if I can remember them.
I don't
Um,
remember mine.
no. Okay, so I let's see. I applied to PA school in 2016. It was like September, I want to say, when I submitted my application. Interviewed in November, and I started PA school May 2017.
How many schools?
Yeah. Okay, so I would recommend a minimum of five. Don't do what I did. I applied to three.
Oh, wow. Okay.
And I kind of just did like two early decision and then one later.
Hmm.
And yeah, I got one interview and interviewed at that one and then got it.
That's
I was
awesome.
actually waitlisted. If this helps, I'm just going to be transparent.
Yeah.
I was waitlisted and then they had like one more round of interviews. And after that interview went through, then I got the phone call right away after that.
Yeah.
So for all of
Awesome.
you waitlisted, it's possible.
It happens
It
every
does.
day, every
It
day.
does. It does.
Um, and it's important to know that, so you applied to three schools. Was that just because of location preference or just
Yeah, so I did one in Washington State, one in California, one in Oregon. The
Mhm.
way I trimmed it down was I looked at all the schools and saw what my prereqs were and whether they required the GRE. I don't want to take the
Yeah.
GRE. And I didn't want to take extra classes that my undergrad didn't have. So I trimmed it down and I had like a running list of 10 and I
Okay.
picked my top three and just did those three at first,
Okay.
knowing that a few were early decision
Yeah.
because then that would also save money. And then I knew that I could still apply in like November and submit more if I had to. But
Okay.
fortunately, I
So
didn't have
that's
to.
actually an important point. And I think sometimes, and actually, till I started doing this, I didn't know that either, that you could, apply and get your application
Mhm.
verified. And then if you want to add schools later,
Yep.
you can do that. So, like, if schools have a supplemental and you have a group of schools you want to get in and apply to, and they don't have a supplemental, then apply to those first, finish your
Mhm.
supplemental, and then
Exactly.
apply.
Exactly. Save a
So
lot of money.
you do, and you don't drive yourself crazy with trying to get everything in at once. It
Hmm.
wasn't like that in 1975 when I applied. I'm kidding. It wasn't that old. But it was like when I applied in 2003, it was not like that. You kind of had to do, first of all, it was like the first year that CASPA was even open. So
Wow.
it wasn't even fully electronic. Like they
Yeah.
printed out your application and then
That
sent
is
it.
crazy.
And I think there was like maybe 40 schools on there. There wasn't, tons of schools. So a lot of them had separate. So I remember doing CASPA and then all of these like applications that were completely separate,
To that
from the
school.
schools and then like
Yeah.
sending them in. So it was insane. But But at that time, that's how it was. So, they had deadlines and things, but you kind of were just like, I can't do this like
Hmm.
forever. But now
Hmm.
you don't have to do that, which is kind of nice.
Hmm.
Now, 3 schools is pretty low.
Yes, no, that's where I tell people don't do what I did.
So,
I had intent to do more. I just didn't need to. So I got lucky, I would say. But
yeah.
yeah.
So, how
So
many
my
patient care
stats.
hours do you think you had?
Yeah,
Yeah.
no, great question. So I definitely knew I didn't want to be a minimum applicant, what I like
Hmm.
to call it. Kind of apply when you know you're at least going to get an interview. Don't just meet those minimum criteria. So I honestly like, okay, GPA was, I think, 3.9. I had like
He's a
four,
genius, folks. He's a
yeah.
genius.
I had like 4,000 volunteer hours. So I definitely think that's what set me out,
Yeah.
was the volunteer, because my patient care hours, I had a year and a half of hours. So only like 16,
Wow.
1800,
Okay.
which honestly wasn't that much. My school required a minimum of 1,000, that the one I was
Okay.
accepted to. So I had a little more than there. But
Yeah.
when I looked at my cohort, I mean, I was 22 when I started PA school, and like I think everyone else, a lot of them were 30s, and so
Hmm.
a lot of them had more hours, but my GPA was a lot higher, and I had a lot more volunteer hours. So
Right.
I'm kind of wondering if that kind of helped facilitated.
Yeah, and I think everybody's a different applicant,
Yep.
right?
Hmm.
So, your GPA doesn't have to be a 3.9 if you have, other things on your
Yeah.
application that make you a standout. I actually think my GPA was probably a 3.7, like 3.6, 3.7, I don't
Hmm.
remember, but something like that.
Yeah.
But I only had like 900 hours of patient care experience, but I had tons of research experience.
Right.
So I think that helped me
Right.
as well. I
I
mean,
agree.
obviously it's much more competitive now than it was then, but I think that helped,
Hmm.
between that and
Hmm.
volunteering and stuff like
Hmm.
that. So,
Hmm. Well,
um,
because we all have to do that research project during school, and I also, having that research background, I wondered if that helped too, kind of having that publishing process and knowing
yeah,
what it's like to write a paper. So
yeah,
yeah.
no, it definitely helps. So, I get a lot of people wanting to apply to 25 schools, and then I have other people that are like, I can only apply to 3 schools because of my location. I'm married, I can't move, blah
Right.
blah blah. So, if you're applying to a smaller amount of schools, you definitely want to be above the minimums,
Yep. Hmm.
on those to
Hmm.
maximize your
Hmm.
chances for sure.
Hmm. Hmm.
Yeah.
The other
So,
thing too, like
yeah.
the reason why I picked my school, and this is just my experience, but I have found like PA school's all about clinical year. Didactic year is pretty across the board
Yeah.
from school to school, a little maybe the same just because of the accreditation process. Clinical year is where I found it's like that's where it matters. And my school, I don't know of other schools that do this. You would probably know better, but my school, they put you in one community for the whole year, and
Oh,
you don't
wow.
travel around. And we do family medicine an entire year. You do that for 2 or 3 days out of the week, and then your other days of the week, that's when you go through your specialty rotations, and those ones are 6 weeks. But you
That's
don't have to
interesting.
move all the time. I mean, the ones I traveled to was because I chose to go there. So you have that option if you want to,
Right.
but it's a nice way to maybe save money. It's a great way to get built and plugged in a community. And I knew I wanted to practice in Washington State when I was done. And so I thought, well, why not
Yeah.
start networking and working there now? So I would kind of encourage applicants to look at the clinical year and see how that's set up. And that was a draw for my program.
Yeah,
Yeah.
definitely. I mean, I know, when I was in Connecticut, I went all over the place in
Yeah.
Connecticut. It wasn't like one spot. I know up until about a year ago here in South Carolina, people were going elsewhere for rotations,
Hmm.
all the
Hmm.
time. So that's kind of cool that you could establish
Yeah.
a regular sort of home base
Exactly.
and
I mean,
and
for all
then
those
kind of go
applicants that
back.
have married kids, it works so
Yes.
well for them. Yeah.
That's very cool, because not I some programs must be very similar, but to my knowledge, most of them, it's and people may not know this listening to this. It's not easy for schools to find clinical rotation
No, thank
sites.
you for saying that.
So it is not easy. We got these programs that are basically fighting for spots
Yep.
because of there's med students, there's nursing
Hmm.
students, there's PA students, there's
Hmm.
pharmacy students, there's all these
Hmm.
things, and you're all fighting for the same rotations. And so
Yep.
these people in the PA faculty of these programs play absolute Jenga
Yeah.
trying to
Yes.
get
Great
these
word.
clinical
Yeah.
rotations for y'all. So it's really important to understand that, the the clinical rotation process is super complicated, and
Yep.
it's competitive, for PA programs and things like that. So much so that they recently I think they started offering incentive
Mm-hmm.
or to get preceptors,
Mm-hmm.
right?
Mm-hmm.
On my end, as a practicing PA, I like to take a student on rotation,
Mm-hmm.
but I will say that I can't take a student all the time
Right.
because, when you're in a busy practice and you're trying to get all your documentation done and you're doing all that stuff too, you're like, okay, I can only manage probably 3 students a year.
Mm-hmm. Mm-hmm.
Like I can't take more than that. So,
Mm-hmm.
and I think that is true of other providers. And I think some providers are like, I just can't, which,
Mm-hmm.
is what it is. But
Maybe then that's better for the student, because then maybe they want to have a good experience if that was.
yeah,
Yeah.
exactly. But it is a competition, and it is, so
Yes.
if you are getting sent to other places, it's because that's the best rotation site that they could offer,
Right. I agree.
so that's
And
crazy.
there's actually someone that said yes. So it's definitely a gift they're giving you to be able to spend time with them.
Yeah, I agree. It's hard.
But
um I mean, so did you do an ophthalmology rotation?
great question. So again, with your kind of your core rotations, those are obviously required. And then my school, we got 2 electives. So I did both in ophthalmology.
Okay.
Um, I guess a little side note too to think about. If those of you are thinking maybe eye care for patient care hours and you're worried if that will prepare you for PA school, I totally had that thought because it's pretty narrow and
Yeah.
specialized. And that thought was definitely there when we did cardiology, and I was surrounded by EMTs and RNs.
Mm-hmm.
But then when we did HENT, then I excelled in the tank. So everyone comes from their background. So I wouldn't let that stop you. But during PA school electives, I did both ophthalmology. I went back to my home clinic for one of them. And
Okay.
then I applied to Duke University School of Medicine as a visiting PA student. So
Okay,
I actually
cool.
had to apply to 2 PA schools, which is
Yeah.
kind of weird. And I got into both and did both. It was odd. But there, I was able to do an ophthalmology rotation at Duke Eye Center and their ocular oncology.
Okay.
And
Oh, cool.
their retinal degenerations and like ophthalmic genetics and glaucoma and medical. And I just kind of did a wide scope. So those were 2 of my elective rotations, ophthalmology, and one as a visiting student and one just my home clinic.
Okay. That's cool.
And so when you talk about setting rotations up, this is where I get it when faculty says it's hard, because I set that one up myself, and that took, I'm not lying, that was like an 8-9 month process,
Oh, for
with
sure.
many times being told it's not going to work out, and it still did. So like it's true, like if a student actually tried to set up a rotation, then they would learn what their faculty
Yeah.
means by it's hard.
It is hard.
Yeah.
And some people struggle with what electives to choose.
Hmm.
Um, and if you like have no idea, like me, I was like, oh, well, I came from oncology. Like I was doing, I was a PCA on a oncology floor in the hospital, and I was
Yeah.
doing basic science research in lung cancer. So I was like, oh, I'll do oncology, right? And I have a blog post on this, and I went on that rotation, and I came back, and I was like, there ain't no way I'm doing oncology. Like, I literally remember telling my friend Kyle, like, he's like, how was it? I'm going to do that rotation. I'm like, don't do it. Don't do it, bro. I'm like, go do something else. It was not very well organized at the time, and there was no real preceptorship, and I think that made a huge impact on it. And I just was like, there's no way I could do this. And then my other rotation was like interventional radiology or something like that. And I was like, I literally have no idea what I want to do. And I think that's okay though, because then you
Yeah.
learn what you don't want to do,
Hmm.
but also keep in mind that your rotation experience isn't necessarily what your experience is going to be
Yes.
in a job. Because
Yes. Thank you.
obviously I've been in
You still
oncology
do.
for 13 years.
Yes.
So I think it's important to try different things. I did internal medicine for a year and kind of was like, cardiology, me, not cool. There were certain things I was like, I kind of like that. I kind of like that, and so like you got to kind of feel it out a little bit. I don't think that if you don't get your elective rotation or you're just not sure which one to pick.
Yeah, it's not end all be all.
It's not end all be all.
Yeah.
I mean, you
Yeah.
may never do a rotation in dermatology and then go into dermatology.
Right.
So
Right.
it's just about trying to give you options to see, hey, I might like that or not.
Mhm.
So, but
Mhm.
if you have a specialty that you love, like orthopedics or whatever, and you know that that's what you want to do, then yeah, try to get those rotations.
Right. Yeah, I like what you're saying there because sometimes it isn't the medicine you don't like. It really is just the venue and the avenue it's being done in. And that
Yeah.
was when I was at Duke. I loved the medicine, but I found I did not like an academic setting. Academic
Hmm.
medicine is so different than private practice.
Oh God,
Um,
yes.
and so, yeah, it's sometimes it's just keep an open mind that it's not maybe the medicine that you like, it's just where it was being done.
Yeah. And that's a really good point. Working in academics and working in private practice as a PA is very different. As any medical professional
Hmm.
is
Hmm.
very different. And I think it's you kind of feel your way through it. I
Hmm.
worked kind of in both settings. And because Dave is in academic medicine, I always wind up in a place where I'm at an academic medical place.
Thanks, Dave.
And so thanks a lot. Okay. But I like it. I
Yeah,
like it. So, it's there's, research. I mean, it's just different. It's just a different
yep,
thing. But like specifically for surgical PAs, I feel like being in a private practice, you get more opportunity. Do you agree with that? Like just
I
because of
think so.
residents and fellows
I
and,
think so. Yeah.
all of that,
Yep.
less opportunity to be in the OR,
Yep.
you
I
know?
agree 100%.
Yeah.
That's yeah. That was the same thing at Duke. It was me with residents and fellows. I mean, I was the only PA student, but
Yeah.
you're kind of sharing everything. Private practice, you get a lot
Now,
more
be
autonomy.
real. When you were on
Yeah.
rotations, were people like, what the heck is a PA student?
Oh yeah. Oh yeah.
Really?
Oh yeah.
In 2016?
Oh yeah, for sure. Like, and that you did the cliche, like, oh, are you going to be, when are you going to go to medical school then? Like, they
Yeah.
almost think like PA is just that stepping stone into med-
Yes.
I'm like, I'm not. Like, that's what I'm doing. Yeah, all the
Yeah.
time. Especially too with ophthalmology. Like, people like, what? Why are you here?
Yeah.
I
Did
never thought of this,
How did you explain it?
I just explained that this is what I want to do. This is what I want to go to do going to PA school. And I kind of validated the whole PA school experience though. And that's what maybe other students like. I loved learning everything. And
Yeah.
I literally came out of PA school being like, I would be happy doing like OBGYN, but I knew I loved ophthalmology.
Right.
So when I'm there at Duke and it's people that don't know me and I'm the only PA student, they're just kind of like, oh, that's cool. And then I'm like, do you really think it's cool? Or am I kind of in your way and like coaching? Fortunately, I think for me, having my background and I could kind of talk terms, my mentors, they kind of warned me like, you're going to know more than your first or second year resident in
Hmm.
ophthalmology.
Yeah.
That's because just like PA school and medical school, you don't learn ophthalmology to the level that you need to know practicing.
Yeah.
So residents don't learn it till they're a resident. So if I come in with almost 2 years of experience, I'm already going to know more than residents. So
Sure.
that I think gave me some accreditation is I'm on a rotation with the first year resident and I'm knowing more than they are. So I think
Right.
kind of, which I would hope this in just regular life for the rest of the time, that people don't like you really for your credential behind your name. They don't
Yeah.
remember that. They remember you for you and the care
Yeah.
you do. So yeah.
Yeah. Very, very true. Very good. But, I'm not surprised that people are still, not as familiar as they should be with the
Mhm.
profession. I think, I used to get this all the time. Same as what you said, like, oh, so then when are you starting medical school?
Mhm.
Or how
Mhm.
long will you be here? You're going to rotate out soon because they're used to having like a resident or fellow or
Mhm.
whatever. I'm like, no, 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 I don't go anywhere. This is like my job.
Yeah.
And, and over the years, I feel like that's gotten significantly better,
Mhm.
but I still feel like sometimes I'm doing the education, but like you, it's okay for me. Like I'm
Yeah.
not
It doesn't.
flustered by that
No. No.
at all.
Mm-mm.
Because I'm solid on what I do and what I know I
Right.
can do,
Right.
and what I can offer a patient. So I think that's a really important thing, to say. And I don't want students that are on rotation to be intimidated if someone's like, oh, you're just a PA student, or
Mhm.
oh, whatever. You just kind of do your thing,
Mhm.
like
Mhm.
know why you did this, go back to your why. And I think, you can't be flustered if
Exactly.
you are solid in your foundation. I had a patient, I've been seeing him for months, and he came in and, for some reason, so usually the doctors and I kind of rotate visits. So like I'll see the patient a couple times and they'll go back to the doctor and then back and forth, right?
Okay.
And, the physician had been on vacation, so like seen me a bunch of times, and all that. He's like, so tell me a little bit about this physician assistant, situation. How much do you make? I'm like, excuse me.
Oh, jeez.
I was like, whoa, just diving right in, right?
Right.
My response was like,
Not enough.
not as much as I should.
Yeah.
And then, his little sweet wife was like, oh my God, and she asked some very, very good questions, right? Like, oh, well, how long's the training? Oh, well, so very good questions. And so you just kind of got to work with people as they sort of work through this, and as our profession becomes more and more prevalent and known, it will get easier over the years. So,
yes.
So hang in there for all you students. But one of the most amazing things about this profession is that we are trained in a lot of different areas. So, you've been out of school for a year,
a little less.
Year and a half. Oh, okay, a little less. So what was the learning curve like for you when you got out? I guess not as much because you were already doing ophthalmology.
Yeah. So my first job out of PA school was family medicine because I couldn't find any ophthalmology positions for PA. For those of you that don't know, there's only 76 in the country. So it's
God
rare to find a PA interested in ophthalmology and a place interested in a PA to do ophthalmology.
Yeah.
So my first job outside of PA school was family medicine. I actually joined the practice that I was at as a student for a whole year.
Awesome.
So that was pretty fluid just to move right in because I knew everyone, the EMR. That learning curve outside of PA school was, I'll just be transparent. I inherited a physician who retired that year, his practice, and he had them for like 40 years. So patients are really used to things being done one way for 40 years. And I'm a new kid, a lot younger. I come in on the block and I'm doing things a little more current, but that's a lot different. And so the learning curve wasn't as so much the medicine side. It was definitely more that interaction and some of the politics that come in.
Yeah.
And learning what it's like to take care of other people's patients that are now yours and being true and sticking to what you know is the right thing. The temptation's going to be there to cave, to give in, to not cause conflict. You're kind of trained to not cause conflict. But sometimes you have to do the right thing. So that's definitely a learning curve that I didn't know going into it. As far as the medicine, my practice, family medicine, was very heavy internal medicine.
Yeah.
But I honestly, I had to look things up, but I'm not just saying this to say this. I genuinely was shocked at how much PA school trained me. I was blown away. I was like,
wow. Okay.
It wasn't as bad as I thought it would be.
Yeah. So again, I think I did like inpatient internal medicine as a hospitalist the first year.
Right.
And I also felt prepared for that. It was when I switched that I was like, I am underwater right now. I don't know what these drugs are. I don't know what's what. I don't even know anything. And so, it takes about 6-9 months, for you to get your footing and be like, okay, I can do this. That's kind of what it takes. But you forget about the politics of offices and people who are used to seeing a certain person, and you go in and you're new and, all of those kinds of things. So I think it's important to, like you said, stand your ground. Now, you got to be honest, because I'm sure, do patients comment on your appearance?
Yeah. I mean, we could talk about some of that. So yes.
So those of you who can't see Joel right now, he is a young, very attractive Caucasian male. And he looks young. So I'm sure your patients sometimes are like, how old are you?
Yes. Right? So no, we can totally talk about this. I get asked all the time if I'm in high school. I honestly make a joke with it too. I just kind of go with it. They ask me like, are you married? Are you single? Comments. I mean, I could throw out, do you want me to say things that patient said to me?
Oh my God. Yes. This is awesome.
Okay. I had a patient. So this is when I'll give you some in family medicine and then some, because I now work in ophthalmology. So family medicine, I had a a lot of grandmas like set up me with their daughters. I had like patients would talk to my nurse and try to get my number that way. I had a patient ask, this is like, I'm doing in ophthalmology, I'm doing an injection in her eye. And she literally asked, like, I quote, "Can I grab your balls?" And I was like, okay.
No, no. What did you
and it's
say?
not just like that. I was like, I think I need to sign a waiver to work here. Like a joke. That's like, I guess what I want to say is like a lot of people talk about how it happens to women, which it does.
Right.
And I don't dismiss that. I really don't.
Yeah.
Because it does happen more to them, but it has equally happened to me several times, both men and women.
I can account for that. Yes. Go ahead, finish. Yeah.
Like I've had male patients hit on me and I'm straight and like I can get along with them. It's fine. But like I was doing a prostate exam on a guy who was complaining of rectal pain.
Right.
And I found out later he made up these symptoms to come see me.
Oh boy.
I'm like, we're being real, but I'm doing a prostate exam. And as my finger goes in, he looks at me and he goes, "That feels good."
Oh my God.
Yeah. I was like, I walked out and then like went to my nurse and I was like, all right, like we're going to treat him for prostatitis and I'm going to go take a walk in the ocean. Like,
yeah, I just got to get some air. Got to go get some air. Yeah. I think the important thing to remember though, is that you can't predict what people are going to say to you. Mm-mm. And the whole point of, us kind of sharing this is that like, you don't know what's going to come out of a patient's mouth. You have to remain calm, as professional as you can. Mm-hmm. And when you leave the room, just go somewhere else.
Yeah. Oh yeah. I was
and either laugh or scream or cry or whatever you're going to do. Yes. Because I mean, so I will say this, as a woman, I have had inappropriate comments said to me. I just don't address them. Like I'm one of these people that I'm just like, not even gonna like address that. So, I'll have somebody be like, so, are you short of breath? And they'll be like, well, I wasn't till I came in the room. I'm like, okay, so do you have cough? Or, I just like keep going.
Yeah.
Like I'm
the
not.
The only time I've like actually addressed it is I had a patient physically call my butt. They nicknamed it Fella, which then the whole clinic started Fella. And she actually like rubbed it and like, did one of these.
Well,
like,
that's inappropriate.
Yeah,
I mean,
and
that's like,
when I was like, all right, we got to call that out because you actually physically touched me. But I'm like you just kind of move on and
you just kind of move on. Yeah. Again, I'll call patients out though too. Like I was bending over to do like listening to somebody's heart and I was wearing a V-neck shirt and it wasn't low cut, but my reaction is to just kind of go like cover my hand just because like, and he goes, I ain't going to look down your shirt. You ain't got nothing to look at. I'm like, listen, bro. I was like, so I was like, okay, I like you, but this is inappropriate.
Yes.
And just like, I am okay with that. I'm actually okay with that if people are mean to me. Like, I'm like, you know what? I understand that you're upset. I don't deserve to be spoken to this way. I'm going to excuse myself from the room. You can always excuse yourself from the room. No one says you have to take care of a patient that's abusive to you, either, sort of in an angry way or in a sexual kind of way. You don't have to deal like, you deserve the same respect as anybody else. You're not going to treat a patient like that. They're going to, but at the same time, it's amazing what people will say. I work with a male physician and a female physician. And I can't tell you how many times I'll see a woman, and they're like, where is he? Is he in? Yeah. And I'm like, okay, all right. And the one lady was like getting an EKG and I walked in the room and I was like, oh, hey, I just wanted to say, and she's like, oh, I was hoping you were like, so shirt wide open. And she was like, oh, I was hoping you were the doc. So it does happen to men too. It happens to women. It shouldn't happen to either one of us, but it's going to happen. It's going to happen. And I'm so glad we addressed this because
I wasn't planning on it, but I like this.
It's going to happen. This is real life, like what happens in practice. And like I said, you can never predict what someone's going to say to you. Like never. Sometimes I'm just floored. But the most important thing, like we said, is to just maintain your composure. If you're super uncomfortable, there is no reason for you to stay in the room with that patient. You can
Mm-hmm.
easily excuse yourself out and like get somebody
Mm-hmm.
else to take
Mm-hmm.
over. So that's probably the most important message, you know,
Right.
from all of it is
Right.
that keep your professionalism, stay calm, and, you know, get out of there.
Yeah, exactly. That's what I normally do, is just leave. And a lot of these scenarios too, when it's a female and I'm doing maybe more sensitive exam in family medicine, I have a chaperone, like, and we're trained to
Right.
do that.
Yeah.
My female colleagues, though, a lot of them, they didn't have a chaperone when they were doing male exams.
Right.
But
Right.
men do it for women. But like, I didn't have a chaperone when I was with that guy, because it was just
Right. Because it was
like, oh,
guys.
it's a
Yeah.
guy.
Right.
And then
Right.
you never know. So
Yeah. Yeah.
yeah.
That's true too. Good point. If you're going in and you know this patient, they know that like it, you know, then bring someone with you.
Yep. Mm-hmm.
I mean, it's all the time. Like I'll be like, nope. Hey, my nurse, you're coming with me.
Yeah.
Because
For me.
yeah. Yeah. Or even if you're worried about the patient being angry or something, like just bring
Yeah.
somebody with you.
Yep.
Or notify people beforehand and you can work on that. But
All the flags.
yeah, exactly. Okay. So Joel is in Washington, as we talked about. So, you know, he has just done something that I may also have to do, but have been in a specialty practice for a really long time. And he has been working night shifts in the ER for the COVID pandemic. So you just kind of went from ophthalmology, jumped back into the ER. And here I see him like, you know, saying he used bedside ultrasound and like all this stuff. And I'm like, oh my God, if I have to do like, you know, it's not that I can't do it, like being in specialty practice, I just have to like relearn. So how is making that kind of shift,
Yeah.
you know, for you?
Yeah, great question. This is what I love about being a PA. When you apply to PA school, a lot of us go into having the ability to change between specialties.
Right.
And I just did that. The other thing too is we all talk about, I'm sure in our applications, we use the phrase like, I want to be a lifelong learner. Like, let's just be real, right? Well, you just got asked to do it.
Lateral mobility.
Yeah. You're being exposed to now this something that we don't know anything about. So if you actually really want to be a lifelong learner, now's your chance.
Yeah.
So when I jumped into the ER, it was because we needed volunteer providers.
Mm-hmm.
I am shocked at how much comes back to me, and probably because I am a recent grad.
Yeah.
But my ear irritation was like a year and a half ago, but it does come back to you. So I'm hoping that other people, if you're going to have to do this, that should come as well. What it has been like in the ER, yeah, I've done night shift, see a lot of COVID patients, whether you're testing them or treating their symptoms, because so COVID-19 is the disease of a virus, SARS-CoV-2, which that was present in the early 2000s. So we've known about SARS before, and this is just one of the strains. And the way it works, and I don't know if we want to get into this detail, but I found it really helpful in knowing these patients are going to come in. But this virus, when it happens in your body, it needs what's called a spike protein to have that DNA of the virus enter the cell and have a protease to like cleave into the cell. Mm-hmm. And this virus then, once it cleaves into that cell, it attaches to your angiotensin converting enzyme 2 receptors, which are in your lungs, your heart, your vascular system, and your small intestine.
Yeah.
So when you understand that the virus is going to attack to these receptors, that is why some patients come in with marked hypoxia, with acute kidney injury, we have seen cases of, and you probably read, like myocarditis.
Yeah.
And it makes sense now when you understand of where these viruses are attaching to the receptors, and you're just having this global end organs are affected by this. Well, now you're going to have end organ failure, ARDS. So some patients come in and they're so hypoxic, and you know they're 80% on room air sat. I think I talked about her in one of my stories on Instagram. She actually did test positive and had to be admitted and go under through all that. And some patients, we test them and they're positive, but they're able to stay at home. So everyone's different.
Yeah.
The median time we're kind of seeing like severe dyspnea or like shortness of breath is like 5 to 7 days.
Yeah.
And then on average, we're seeing once patients are admitted, it's about, on average, if they have like the full blown, it's about 1 more day after admission to be intubated.
Wow.
So,
okay.
So in the
Scary,
ER,
scary.
I guess to share the like when I know what's going on, pathophysiology of this virus and the ER perspective, what has been interesting, like outbreak medicine, you have to think differently. It's different. You can't just go into a room when you want to.
Yeah.
And you can't just like go in there however many times and people. So
Right.
you're also trying to like salvage like as much PPE as you can and not use
Right.
as much. So like the nurse, she'll go out, she'll triage the patient, bring her our ER. We've converted to isolation rooms, which like
Okay.
to be transparent, it's literally like plastic tarp from ceiling to floor with like the blue painting tape, and it's so sketchy. Um, so we have that, and then we bring them in the room. The nurse, she'll put on her PPE, do like initial set, and if she thinks to swab them, then she'll go ahead and swab them, and then she'll come out, present to me, and I'll like wait to get the like, because normally we'll swab for influenza as well, so I won't go in there until we get that back, because that's like 20 minutes.
Right. Yeah.
So you're kind of just like doing what as minimum at times you meet them and doing whatever you can in one visit. So then I'll go in, put on my PPE, which my hospital, I've been grateful to have. We have like the cappers,
Oh, nice.
gowns. Yeah. So we're pretty fully protected.
Yeah.
Go in there, um, do your encounter, do your exam, and you try to do everything in that one visit and
Yeah.
figure out whether you're admitting or sending them back home.
Right.
And from an ER perspective, you have to think, if you're admitting them, what should I order now that sets up the admitting team for success?
Yes.
And when you look at the treatments of what we're doing, a lot of this, because of when you understand that pathophysiology of the virus and what it's causing, well, what you also having is this cytokine inflammation that's just attacking everywhere. So you have your immune system is just going crazy. So your treatments are a lot to reduce inflammation, antivirals. And one of the drugs we're doing is like, hydroxychloroquine or chloroquine.
Right.
And like, I'll be honest, I didn't even think about this until we had a patient who was G6PD, that
Oh,
anemia,
yes.
and that medication.
Fava beans.
Yeah, right. I know, right? But like hydroxychloroquine or chloroquine, those patients that are that type of anemia, it can cause that lysis of those RBCs. And so just really trying to think like, what do I need to do in the ER to set up admission team for success? And if that means I have to order that test, which normally you wouldn't.
Yeah. Yeah.
But knowing that that's a treatment that we're doing right now, well, maybe you should if they're that type of patient. So yeah, just kind of thinking at global scale.
Yeah.
Again,
but you're also seeing non-COVID stuff.
Yes. So that's the other thing. So you go in a room and then you're still in ER. Like literally last night I just did a night shift, and like we walk in and I'm like, this is an ER. We had, your motorcycle crash, your overdose, your abscess, your chest pain, everything under the sun. And so you're just bouncing back and forth in rooms.
Yeah.
And it's kind of weird. Like when people talk about healthcare workers on the front lines of this, especially night shift, it almost seems like our world in our little ER 12 hours. Like when I start, so I do 7 to 7. So I know like when I start my shift, my family or girlfriend, they're all spending their evening and then they go to bed. And I know when I get out at 7 a.m., they're probably just waking up.
Right.
And their life moves on normally. And they kind of expect that your life also like continued at that pace, but it really didn't, because you spent 12 hours in the ER doing COVID and chest compressions and overdose. And then you have to recover from your night shift. So if you're going to volunteer and do this, just kind of recognize, obviously your COVID patients, but you're also going to do your suturing and your ultrasound and your overdoses. Has been amazing what comes back though. So to be completely honest, I have never felt so much more encouraged of being a PA. And
wow, good. I love that.
And like, I'm not just saying to say that, like, and I mean, I guess to clarify, like, this is volunteer. I'm not compensated for this at all.
Right.
I'm
so this is basically
in so
like
many other ways.
Exactly. Yes.
It's not just monetarily. It's the ability, like, this is what a lot of us are drawn to medicine, those times where you help these people in these moments, and you're doing it not for money or just because that's the thing to do.
Right.
It really is like, this is why I wanted to be PA, and it's been awesome. So
I mean, I love hearing that. I get asked a lot like, why do you do oncology? It's so depressing,
Yeah. Oh, I
all
bet.
of that stuff. I mean, there's so much more that comes out of it
Hmm.
than
Depression.
just the patient care. There's so much more that comes out of it other than the medicine. And,
Hmm.
I think that's important to remember. I think that's why everybody is trying to lobby for PAs to be more involved in this
Hmm.
pandemic because,
Hmm.
we do have the training. I think, I may have to go back into an urgent care setting or onto a
Right.
hospital floor. If that happens, I think I could make the shift to an inpatient position a little bit easier than to an ER, just because I practice a lot of internal medicine, as an
Right.
outpatient.
Oh, yeah.
If they ask me to do that, I'm going to do it. And, it's short term,
Yep.
it's short
Yep.
term. And I think if as providers, we are able to help, then we should. And I'm kind of with you that the rewards are not always necessarily paid
Yes. Yeah.
rewards. And so, just being, transparent about that, I think is important. But it's also, again, a lot of the reason why we all went into medicine in the first place. So what do you think has been the hardest part about being a PA? Like whether it was school, pre-PA, now in your, last couple of years, what
Hmm.
has been, the hardest thing for you, and would you do anything different?
Yeah, great question. Um, I mean, I can think about it in all these different scenarios, but honestly, the hardest part was a part I never anticipated. I think a lot of us that are drawn to medicine have this moral imagination of medicine where it's all things moral, you want to help people, but it's just imaginary because you've never actually done it.
Yeah.
And when you actualize that imagination and do it, the hardest part for me so far as a PA of practicing in all the settings that I've been in. I mean, could I say, is it trying to be an ophthalmology PA and being told no all the time? Yeah. But it's more honestly the times when you are like, when you're talking to a patient and they're sharing you a need, it almost as if seems like the relationship can be a little fake. And let me
Hmm.
clarify that. Where patients will open up to you about something. And if we were sharing a meal, I could say, hey, I've been there, or I struggle with that too. But
Hmm.
you can't because there's like this unspoken patient boundary. I mean, I guess
Yeah.
you can, but you also like that balance of, am I crossing a boundary by sharing this side? And I'm supposed to just be with this patient. And so it's just taking all their needs. And then I found it's like, wow, like I'm horrible at communicating my needs because like just in life, like outside of it, because
Yes.
you go through all this training that really is arduous and it has the power to change you. And you don't
Hmm.
realize over time that you're taught to not communicate your own needs, just
Hmm.
hear other people's. And so when you're doing it out as a PA and then you have that role, but then you have the rest of your life and you're trying to figure out how to live with family and friends and all
Yeah.
these people, that I would say has been the harder part is learning um, just how to communicate my own needs to people because I spend most of the day hearing other people's.
Right.
Um,
Yeah. I mean, it's true. And it's hard to turn it off. Um,
yeah,
and I had this conversation with Dave because he is a, very introverted guy to begin with.
right.
And then, he comes home and he's kind of off, and I'm like, what is the
What's
problem?
wrong? Right.
Me, I have like verbal diarrhea. I'm like, what is the problem? Like, use your
Yeah.
words. I feel like I'm
Yeah.
talking to my 5-year-old. I'm like, use your words. But it's taken time for him to be able to do that,
Hmm.
because you do spend so much time trying to help other people, kind of solving their issues,
Hmm.
being um, the person, with them, that it's often hard to then just go and say, you know what, like, this is what I need right now. Like, I need to just like be by myself, or I
Yeah.
need to like go for a run, or I
Yeah.
need a glass of wine, or, whatever it is. But it's hard to do that, especially if you have a partner, especially if you're, you know,
A mom, a
a
dad, it's just
mom.
another role.
You got to turn it off.
Hmm.
You got
Hmm.
to turn it off. And it's not as easy as it sounds.
No, no.
It's
Mm-mm.
not as easy as it sounds. And
Hmm.
that's actually a really, really important lesson, I think,
Hmm.
for anybody that's going into a medical career is boundaries
Hmm.
and
Hmm.
boundaries and then but still allowing yourself. So for me, I see my patients a lot and they're going through a hard time, and so there are times where I share a personal
Hmm.
experience
Hmm.
because it helps them understand a little bit,
Yes.
and one of the questions patients ask me all the time is like, if I was your mother, would you recommend this?
Hmm.
If I was this or
Mm.
if I was that.
Mm.
So challenging. But again, usually what I'm recommending or what we are recommending as the team, I believe in it. And so I would be
Right.
like, absolutely,
Right.
and that's a question I think when I was younger, I didn't like to answer, but
Right.
now as
You're
I've
more
been
comfortable.
more comfortable, I'm seeing my patients every 2 weeks, every 3 weeks, like, so I get to know them really well. And so, yes, there are times where they will not, or just be, okay, I don't want to start an antidepressant, or I don't want to do this, or I don't want to do that. And I was like, look, here's the deal. Like
Hmm.
and like if I share
Hmm.
something with them that I identify with, I feel like it makes our relationship stronger, but also they see me then more as a person,
Yes.
and not, you know, just a provider, which is nice. But again, there has to be those boundaries there.
Yeah.
And
I think you're right. I think you kind of know which patient you can do it with. It's
yeah,
just the sixth
yeah,
sense that we all have.
yeah.
I've had patients where when I started learning this and realizing this, there was a couple people that I was like, you know what, I'm going to do what you did, where you know what, I'm going to just say, hey, I've been there. You're not alone.
Yeah.
And patient's response, I had one patient like that stands on my mind. And she just said, hey, thank you for talking to me as a human, not a patient. And I was like, she gets it. She gets the
Yeah.
difference
Yeah.
because she
Yeah.
knows what it's like to be talked to as a patient versus a human being. And I
Yeah.
know what it's like to talk as a provider versus a human being. And there is,
Yes.
and
Oh my God. Yeah.
we both
Yeah.
connect to that human side. So I agree with you. And that has been honestly like one of the healing parts is kind of being like, well, you know what? Screw the boundaries. Not like, I don't mean
Yeah.
all the time,
Yeah.
all
Yeah. 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 Exactly.
the time.
But sometimes, you just gotta, we are human beings,
Yep.
right? I
Mm-hmm.
am going to make mistakes in
Mm-hmm.
people's care. I have made mistakes. I will make mistakes. I
Mm-hmm.
learn from my mistakes.
Mm-hmm.
And I think that it's important for people to understand, like, we are human. Things happen. We may get emotional. We may have a bad day. We may, and so I think it's important to not keep those things so inside of yourself.
Yeah.
Not that you want to be sharing that with your patients or whatever, but just know that, it's okay to feel those feelings, and you
Right.
can step out and go outside
Right.
for 10 minutes, or, do whatever you have to do.
Right.
But just being able to show people that we're here to take care of you, and we're your provider, but we're also
Yep.
people.
Yep. And
And
honestly, like being a volunteer ERPA, where I walk in the room and if a patient starts kind of giving me a little bit like, oh, I'm like, hey, look, I'm volunteering my time to be here.
yeah,
And like, and it kind of, I think, puts in proper perspective of like, we don't have to put up with a lot of stuff we have to put up with.
yeah. And now, did you ever, this is probably the last question I'll ask you, but did you ever want to be a physician?
I toyed with the idea when I was in ophthalmology, when I saw kind
Hmm.
of the surgery side of things. And I actually did apply to medical school and I took the MCAT and then
Hmm.
I pulled my application because I just knew I was like, no, I need to go to PA school. And
Interesting. Okay.
yeah, and I never wanted to, in the roles that I've been in, family medicines especially, my day did not look any different than the physician as a PA.
Yeah.
Absolutely zero. It's the same. In ophthalmology, am I the main surgeon? No. Clinically, I'm doing pretty much everything they do, but then I'm a first assistant surgery and I'm content.
Okay. Yeah,
And I
totally.
have
Yeah.
no like feelings of inadequacy or like, oh, I should have done more. Um, no, honestly, no regrets.
Yeah. Me neither. Like I feel like that I knew that from the beginning. Like
Yeah.
I knew that. I knew I was going to be happy, doing my role.
Yep.
And I love working with my docs.
I
Like
do too. I do too.
I
Yeah.
just am like, I love having, so I think It's just a different perspective. And we covered so many awesome things on this,
Well,
and I really appreciate your time and you being here. And I'm so, proud that you're giving back to your community and are just being an amazing role model for so many PAs out there. So thank you very much.
well, thank you for inviting me, and thank you for all you've done for me and just everyone around you.
Thank you. All right. Well,
All
we will
right.
see him next time, and you guys can go follow him on Instagram. What's your handle?
Joel_PA.C.
He had to think about it, y'all.
I
I'll put
did.
it on here somewhere. All right. See you later.
All right. Bye.